Thank you very much for that introduction, but also hearing those very interesting insights, and I'm really impressed by both the bike ride and the walk, but also everything else we heard. So I thought that was amazing, actually. So congratulations to everybody on that. You heard enough about me and where I work and what I do. So I was a little bit thrown by being asked to talk about past, present and future CLL treatments when I saw Professor Follows on the programme for an hour and 10 minutes before me. Because I thought, what on earth am I going to talk about if George has already had a good go at all that? Anyway, we did confer, rather late in the day. And I'm going to try and frame quite a lot of what George said in a slightly different way, and I hope this works. But I'm going to think a little bit about what we used to treat people, and you've just heard about that on the podium. And what we used to treat with people was not very, very long ago. But also, how did we realize, or how did we think we were being successful with our treatments? And I'll also think about what everybody may be receiving today, and a little look at the future, although I'm going to open that up, I think, for the panel a little bit, and maybe the room. So, what treatments do we think about, and how do we measure success with them? And these have changed over the years. So, you've heard a little bit about chemotherapy and chemoimmunotherapy. These are all long words. We now talk about, some people call them novel treatments. I think that's wrong, because the novel treatments have been around for quite a long time, and I don't think they're new. I tend to use the word targeted treatment, which again is not a perfect description, but it's better than chemotherapy. And with those, I'm talking about the BTK inhibitors. So we're talking about ibrutinib, and now acalabrutinib, zanubrutinib, maybe pirtobrutinib. We're talking about BCL2 inhibitors, which is venetoclax. We still talk about monoclonal antibody therapy, and the classic one was rituximab, but today we really think more about obinutuzumab. And then there's a lot of other agents, which I will touch on briefly at the end. And actually, I was struck just reading the Sunday Times on Sunday that the degrader class of drug was discussed quite nicely in an article there, and I'll touch on that. And it was very well described, I thought. And also made me relieved, because I thought, well, hopefully my slides aren't too confusing. How do we measure success? So it's easy to measure some things, and I'm afraid overall survival is one of those, because that's actually not a difficult thing to measure. We also talk about progression-free survival, and we've talked about that a lot in CLL, and that really has come to the fore as the way we measure success in a clinical trial. So all those Kaplan-Meier plots you see generally are progression-free survival, i.e. we give a treatment, and at what time does it then subsequently progress? We can also talk about other things like time to next treatment. The problem with some of these measures is that they can be a little bit more arbitrary, and when you're looking at clinical trial data, you have to have quite hard and defined points, otherwise you can't really compare between different patients and different treatment groups. We've increasingly started to think about something called measurable residual disease, or MRD. It may be known as minimal residual disease. And I'm going to try and explain that a little bit later on. It's quite difficult sometimes to understand what we're talking about, so I'm going to give it a go. What we're not very good at talking about is patient-reported outcomes. And I think we heard quite a few of those being, or not the outcomes, but the patient-reported symptoms in the room earlier. And I do wonder if we could do a bit better in our clinical studies to actually think about those a bit harder, and that may be something we can think about. So, what did we use and how did we measure success? So the chemotherapy era, or the chemoimmunotherapy, and I don't know if era is the right word, but we sometimes talk about it. We have lots of names, we have these drugs, you may have heard of some of them, you may not have heard of some of them. I list them there, they've got different types of things. We like to mix them up, then we put something else in there as well. We also have some antibodies, so that's the immunotherapy part. And then we put them together, and we like to talk to you in acronyms, so we talk about FC, we talk about FCR, BR, CO. Some of you will be very familiar with some of those terms, some of you won't be. I would urge you not to become too familiar with these terms today, because they are no longer that important in terms of treatment today. We will still think about them, we will still talk about them, because we are often comparing today's treatments to these, what I would now call historic treatments. And although I hear that patients are still being prescribed chemotherapy in the United Kingdom, and we are a United Kingdom audience, I'm always rather surprised by that. And I actually find it hard to believe, but I'm told that the reports coming back from pharmacy reviews and things like that is there is still some chemotherapy prescribing going on. And again, maybe that's something for the panel discussion. It's always good to look in historical context. So this man, Daniel Kotowski, actually examined my PhD, as well as I did get the prize. I don't know where you must have found that somewhere. I don't think but anyway, that was a long time ago. But this man was a doyen. He was absolutely essential for driving CLL research forward in the United Kingdom. And he was an amazing man, actually, and he died, I think, 2 to 3 years ago, and he's very important. But I think some of the things worth thinking about is that when he was trying to research CLL and outcomes, there weren't any strict criteria. The criteria that you read about, this stage A, B, C disease, the Binet staging wasn't even written down. The right criteria similarly. And also there wasn't really any way of measuring, if you gave a treatment, what the outcome was. And historically all clinical trials had used overall survival, and that was still used, which I'll show you in a minute. It's not actually that, it's a difficult measure to use in CLL. Also, there wasn't very much to treat people with, so there was a drug called chlorambucil. And we didn't image things. And actually, it was this trial in the CLL, LRF CLL4 trial, which was done in 2007, I'll show you the data in a minute, which was really where things probably got established in the UK practice, but also in similar parallel type studies happening throughout the world, and actually using criteria which everybody recognised, including internationally. So we could compare a trial done, let's say, in the UK with a trial done in the US or a trial done in Europe. And that's really, really important because CLL, whilst it's common, is relatively, in hematological community, is actually a relatively rare disease. So we have to pool our information around the world. And very simply, this trial used this concept of progression-free survival for the first time, and that was very useful because it actually gave us a readout for the study, which we could then build on and use for subsequent studies. And it compared 2 chemotherapy agents and put 2 of them together to see what happened. And this Kaplan-Meier plot, so I think we've seen a few earlier from George, and I think people should understand them. Okay, so this curve here is the one which shows that there was a difference between this FC treatment and the 2 standard arms, whereas the overall survival, which is the way we used to measure everything, showed no difference. And this is important because it told us that actually it did look like this combination of chemotherapy was making a difference to outcomes in this disease. And we can debate about what it means in terms of overall survival later on. This also led on to this, having just told you to forget chemotherapy, to this regime called FCR, which has been used rather a lot, and that basically used the FC combination with a drug called rituximab to make a chemoimmunotherapy. And George showed this slide as well, and it's important because actually this was the first time a chemoimmunotherapy regime or any treatment in CLL had been proven to actually change the overall survival of patients. Up to that point, nothing we'd actually done had changed the overall survival for CLL patients, whereas FCR was a complete game changer with that. So for some reason, adding an antibody to a chemotherapy regime made this difference, and that we can see in this curve here. And that was actually proven by a German CLL study group, but they'd used the information from other trials, and especially a group in the Americas, the MD Anderson based in Houston in Texas, who had pioneered this FCR regime, but had only shown that it was effective. This study actually showed it was more effective in terms of overall survival than the chemotherapy comparator. And this was very important. So here we come on to measurable residual disease, and we have subsequently discovered that those patients who respond best to FCR are those patients who get undetectable measurable residual disease. So what on earth is that? Right, CLL lives in the blood, hence it's a leukemia, and it lives in the bone marrow. We don't have a particular term for that. And it lives in the lymph nodes, and that's the lymphoma bit. So that's a small lymphocytic lymphoma. The blood or the bone marrow is the leukemia, and that's where the name all comes from. How do we measure it? In the blood, we do a blood test, and that's probably how many people in this room were diagnosed with CLL or people with CLL, because they had an abnormal blood test, high white cell count. And as George said, that was then proven in a different laboratory test called flow cytometry that it was indeed CLL. We can find it in the bone marrow if we want to look, and I'm sure some people have undergone bone marrow investigations as well and may or may not appreciate that. And you can also find it in the lymph nodes and spleen, which we generally do by imaging. So we do a CT scan. We don't normally biopsy lymph nodes because we don't need to, because we already know the disease we're dealing with is in the blood. So that's how we measure disease. And then we have to give a treatment, or we give a treatment if we need to, and then we measure the response. And we can do that in a different ways. We can look at our blood tests, and they can become normal. Or we could look at the bone marrow, and that could look normal. Or we could do a scan, and previously large glands have shrunk down in size, and they look normal. And that's when we talk about stable disease, partial response, and complete response. Now, you have to remember that these responses, stable disease, partial response, complete response, are clinical trial criteria, so we can measure outcomes. They're not necessarily that applicable to you or whoever as a patient. For example, the classic one is that most patients who are on a BTK inhibitor only ever achieve a partial response for a number of reasons. But actually, to prove that they have a complete response, we have to do a lot of bone marrow tests, and we don't think that's a sensible thing to do. So it's not, they don't always equate with each other, but they are very useful measures in clinical trials. What about MRD? Well, there are different ways of doing that, and we basically do the same tests in the blood and the bone marrow, but then we look at flow cytometry, or we can look at genetic sequencing and look to see, can we find any cells at all? And we then define that. And if we can't find any cells at all at certain levels, we talk about that being undetectable, measurable disease. What we can't do is look at lymph nodes very well and know if there's any disease there. So even if we say you haven't got any detectable disease in the blood or in the bone marrow, we don't actually know if you've got any disease elsewhere in the body. We have no test for that. But we assume on a scan that there is not really any disease around. But that is what MRD is. And why am I going on about that? Well, here's the picture showing how the blood goes normal, the bone marrow goes normal. I'm going on about it because with FCR treatment, if you had that mutated immunoglobulin gene and you became UMRD, this treatment was amazing, because suddenly we're looking at the top line there, the blue arrow is flat at the 13, 14, 15 years. Nobody is relapsing, this is progression-free survival, with the disease at that point. And dare we say it, are those patients cured? Has their disease completely gone away? We never use the word cure in CLL, and that's again another thing for debate. But this treatment showed that you could achieve that. And that was again the first time anyone shown that. I'm pretty confident with today's treatments we will see similar type results with patients not progressing at 15, 16, 17 years. I don't think FCR is the only way of achieving it, but the reason I've laboured this point is because FCR showed us that this was possible, and that's a very important learning lesson. So, we used chemotherapy and chemoimmunotherapy, and we measured things, talking about progression-free survival, we talked about overall survival a bit, and we also talked about obtaining a UMRD status, becoming unmeasurable disease detectable. So what do we do in the present? What do we use and how do we measure success? Well, now we use all these other drugs, which I wasn't mentioning just there. So we now use obinutuzumab as a general antibody. I've put a picture of Imbruvica there, but it could be acalabrutinib, it could be zanubrutinib, it could be pirtobrutinib, and we use venetoclax. And I'm pleased to say that George has done all of this bit for you. I've got a similar triangle here to him. I'm not going to go all over the trial data. I think he did a very good job of doing that. But what he did talk about was, do we want to give these drugs continuously? Do we want to give them in a fixed duration way? Or do we now want to do it in this so-called MRD-directed way? And that's the FLAIR study, and I will just mention that again, because I think it is important. And we do use these treatments, these regimes, in both patients who've never received treatment before and also in patients who've previously treated. But I do appreciate the question, but some of the things we used in the frontline setting, we're not necessarily using them the same way in the relapse setting, and that's, again, something we can discuss if people want to ask about that. I'm going to try and just explain the continuous versus the fixed duration versus the just for completeness. So continuous therapy is generally given with BTK inhibitors, although we already just heard that John is indeed on continuous venetoclax therapy, and that is another option as well in certain settings. When you think about BTK inhibitors, and this is ibrutinib, zanubrutinib, acalabrutinib, all that stuff I said about MRD turns out not to be at all helpful. A few patients do go UMRD, but it's rare and it takes a long time. And we don't actually find it very helpful to measure disease. We don't change our treatment according to it. And really, we decided to forget all about MRD at that point. So having got excited about this MRD concept, suddenly with the advent of ibrutinib, MRD seemed less important. With our fixed duration therapies, so these are the combinations Professor Follows was talking about. That's a venetoclax plus either ibrutinib or obinutuzumab. We give treatment for a fixed duration and it stops. We might measure MRD as it happens, but we don't change our treatment because of it. And we might say to you, or say to the patient, the result of that MRD is going to impact on outcome. But in the end, we just give it as a block of treatment. We may or may not measure the disease in the ways I've just described, and we go for a period of watching, and that's what we do. Then we have this very complicated MRD-directed therapy, which I'm not going to try and explain now, but if any of you have been on the FLAIR study, or indeed its precursor, the Clarity study, you will realize there's an awful lot of MRD monitoring and a lot of talking about what MRD results are doing. Are they going up and down, and stopping therapy and things like that. And I will just show you a couple of results from the study again, just to reinforce the point, but anyway. And I put a big question mark, because to be honest, we genuinely don't know which the best one of those is to do. So we'll still be trying to conduct trials to look at these different things with the newer drugs, with new arrangements, with new combinations, because we still do not know the best way to deliver treatment for patients, and that's all patients, and it's certain subgroups of patients. And very importantly in my mind, but I was asked to talk about treatments in the context really of trials, I think, it's what's best for the patient in terms of what you want as well, so that's important. So how do we measure success? We still talk about progression-free survival, and we still have these traditional endpoints. We do actually think getting MRD negativity is important or undetectable, but it's not essential in all situations. And what I don't want is people to hear this talk and then go away to doctors and say, what's my MRD result and why are you not measuring it? Because that's not what I'm trying to say. And I think we've begun to think a little bit more about patient-reported outcomes, although I am heavily criticised, and I'm the chair of the UK CLL group at the moment and been heavily involved with the trials, that we don't do this very well, and I think that's an important point. Quickly on FLAIR, and I am aware of the time, but I think I started a little bit late. Actually, it's amazing. This is the cartoon from the New England Journal of Medicine, and I think it pretty well explains everything very well. 2 drugs, you have to do MRD and a blood test. And doing that, we've got this extraordinarily good outcome. Now, this is early results, so we don't know if they're going to be there forever, but to be honest, to get 97% progression-free survival of 3 years, I'm not aware of any other treatment in CLL in such a large group of patients studied in this way where that's been achieved. So I really think this is a game changer in some ways. More importantly, I think probably as well, is if you look at it, at 3 years, almost 2/3 of patients aren't on treatment anymore. So this continuous fixed duration thing may become a thing of the past if we were able to do that. And those are the survival curves, which George has already shown, so I don't need to say them again. So, the present. We're using targeted agents. I put it in inverted commas because that's just the words I've decided to use today. And we're still really measuring success by progression-free survival, a bit of overall survival. And I put UMRD when applicable, because it's not always applicable. The future seems to have been greyed out, which is a little worrying, but what will we be using, and how are we going to measure success? So what will we use? I'm absolutely 100% confident we will still be using the combination of those three drugs I just said, and I still think that will actually be very, very good treatment for the vast majority of people who need treatment for CLL. They will change. We will have new covalent BTKIs, and by that I mean zanubrutinib, ibrutinib, and ACAL cousins. There's another drug called a non-covalent BTKI, and pirtobrutinib is the one closest to market and is already available as an access scheme in this country, and has its role. And then new BCL2 inhibitors, of which sonrotoclax is one. And we will still be trying to trial different combinations. I just put up two here simply because they're running at the moment. There's a Celestial study, which is a fixed duration study comparing sonrotoclax with zanubrutinib versus this regime called venetoclax or obinutuzumab. And that is available in various UK studies. The other one I'm just going to highlight is this static study, and that's looking at can we stop treatments like ibrutinib, and it will probably be modified soon to include additional drugs, because I think that's a very important study too. And I think we'll be using MRD, and that's why I talked about it. So I think it will come to the fore, but there's still a bit of a time to work out how that's going to fit into our treatment algorithms. George showed this slide because I think I sent it to him from a previous talk, and I recognise some of his slides from previous talks I've done. And I'm not going to labour it, but there are lots of targets, okay? I mentioned this drug called pirtobrutinib, and again, these slides I'm not going to really try and explain too hard, but pirtobrutinib does actually work in a different way to the other BTK inhibitors in terms of it binds differently. That enzyme, the BTK, which George illustrated, is the target, and it just works in a different way to block it. And so therefore you might be resistant to drugs such as ibrutinib, acalabrutinib, or even zanubrutinib, and pirtobrutinib will inhibit the enzyme and work. And that's the important measure. And that goes to these degrader compounds. And this picture is actually not that dissimilar from the picture in the Sunday Times, which I was quite surprised. But basically, this is a bit of glue. And the glue brings BTK in this instance towards this protein-destructive machinery in the cell. And that's what cells do. It likes to break down proteins. So the glue brings it all together. And that destroys, in this case, BTK. And again, looking very, very promising in early phase studies as being effective. And also working in patients who are resistant to both the covalent BTKs, but also resistant to the non-covalent BTKs. So there's yet another way of targeting BTK. So you can see we're quite enthusiastic about BTK in the CLL world. People may have heard of these. These are bispecific and trispecific antibodies, and this is bringing T cells, which is a completely different type of cell to the B cells of CLL, next to each other with an antibody, and by doing so they kill the cells. And these are already in the lymphoma arena. They're licensed there. They've been trialled a bit in CLL. CLL's a bit behind the curve with the bispecifics and with some, and the reason for that is because the other drugs we've got are so good, I think, as much as anything else. There are immune deficiencies in CLL which makes some of these drugs apparently less effective, and that's something that the scientific community still needs to get its head around. And one of the reasons why sometimes I think some of these immune-based therapies have been slightly less satisfactory than we hoped, but it's a subtle point. But I think actually mainly the reason why bispecifics and CAR-T, which is the next thing I'm going to show you, is because actually we didn't need to necessarily move that far forward because we were doing so well with what we had. I'm sure many of you will have heard of chimera antigen receptor T cells or CAR T cells. They make the news periodically. They're genetically modified T cells, and I was explaining it to one of my children who is actually a very good scientist the other day, but he's decided to stop doing science, and he criticised me for quite a lot of my way I explained it. But basically you take a bit of a B cell and stick it onto a T cell, and then that actually means that it can recognise the CLL cell. All I will say is the initial promise in CAR-T, the initial studies that actually show that CAR-T worked, were done in CLL patients. And in fact, I remember I was in the US at the time of these being done, and I remember hearing it going, yeah, I've heard this kind of thing before. And actually that was the beginning of this revolution of being able to genetically modify T cells. I was a little bit skeptical because you hear so many times there's been a breakthrough which doesn't move forward. And the reason I put this picture up is because in 2022 it was reported that those original patients, some of them, still had circulating CAR T cells, which in itself is extraordinary because it means they lived to 10 years. But also they didn't have CLL, and showing that actually you can get CAR T to work very nicely in CLL. But we still don't really understand why these very few first patients, some of them it survived and some didn't. And again, generally the number of studies about CAR T and CLL have been relatively small in number. There have been a lot of them, but small in number. And it's just turned to be quite a difficult area to research for CLL. But that doesn't mean to say it's never going to go there. It's just taking a bit longer to get there and things like that. Do we think about enough patient, I'm about to finish my quality of life, both before, during and after treatment? This, I'm sure, is a hot topic. COVID really brought this to the fore. Patients with CLL do have what we call a dysfunctional immune system, but immune dysfunction. Do we think enough about that? Do we identify those patients who actually, although I've just presented a lot of very nice data on responses, some patients don't respond? Are we thinking hard enough about that? I think quite a small group of patients who what we have today is not going to be adequate. How should we be thinking about it? Should we still be talking about progression-free survival? Should we be using MRD? I deliberately put the words toxicity and efficacy in inverted commas, and I also put them in, and I'll tell you why. Because doctors, I know in clinic, have a habit of using these words, which I don't think are very nice. Toxicity is a terrible word, but we use it, and we happily use it because we talk about it anyway, and it's just something we should think about. But so I deliberately put those in to be a little bit provocative. But actually, how do we achieve the best quality of life for patients? Are we good about thinking about some of the things, certainly many of the things out on the posters there, about what's worrying patients or what they're feeling, you know, what you actually feeling you have with CLL? And I still think infection and other related ones. And are we good at measuring the high-risk patients? So future still is blanked out. And I meant to write, so I still think that. But I've said over to you, because I think many of those last questions are best answered together. You and you telling me, let's say, as a clinical researcher, or as the doctor in the clinic, or as the person even in the lab, am I measuring the right things when I talk about CLL? Are we, or do we need to have a bit of a shift? So that's why I've deliberately written over to you. So that was a bit longer than 20 minutes, but it wasn't as long as 40. Thank you.